Okay, Bismillahirrahmanirrahim. Assalamu alaikum and good evening, everyone. I'm Dr. Lala Rokh. I'm a specialist internal medicine at Salam International Hospital. I welcome you all to Al Salam International Hospital webinar series regarding COVID-19 and its varied aspects. Today, our topic will be COVID-19 and heart. Shall I worry about my heart during COVID-19? This topic will cover the COVID-19 manifestations on heart and challenges encountered with its complication and treatment. I request all the participants kindly to turn off your videos and mute your mics, please. This is the area where you can turn off your mic and videos. Just, I think we can let the people to turn off their mics. Dear participants, please mute your mics from here and the camera from here. And this is the chat box. If any question at any time of the presentation pops up in your mind, kindly write the question in this chat box. And it will be noted by me or my colleagues, and answered will be given in the question answer session at the end of the presentation. Now today, to present our topic today, I'm honored to give you our speaker, a consultant cardiologist who is not only the chief of SIH Heart and Vascular Center, but in fact a heart of hospital regular CME activities, and is very famous for his most interactive and interesting presentations always. He is none other than our dear consultant, Dr. Islam Mahrooz. Dr. Islam did his bachelor's degree from Tanta University in 1994, followed by his master's degree in cardiology in 1996, and then the MD cardiology in 2006. He is a member of Egyptian as well as the European Society of Cardiology. In addition to him being a chief of cardiology department at SIH, he is holding many other platforms in the hospital, which shows his dedication and commitment to his portfolios and expertise in many other fields. A few highlights are being, he is a head of Emergency Life Support Committee, SIH, he's a coordinator Cath Lab, SIH, and he's also the head of a medical team for software development in SIH. I'll not take long between you and him, and I'll just pass the stage to Dr. Islam. So Dr. Islam, over to you.
Thank you so much, Dr. Lala, for this very nice introduction. Okay. So before I start my presentation, I would like to say عيدكم مبارك. كل عام وانتم بخير. تقبل الله منا ومنكم طاعتكم. I wish for you a very happy Eid for all of you, and may Allah accept your good deeds all. So on behalf of Salam International Hospital and myself, I'm Islam Mahrooz, cardiology consultant in SIH Kuwait. I would like to welcome all of the audience from Kuwait and from outside Kuwait to our fourth webinar. I hope that it will be, inshallah, very effective and very helpful for all of you. So today, without any further ado, I will speak about very important subject. If it's not the most important subject nowadays among all people, it's trend #1 in all social media and all channel news. It's even more famous than Mohamed Salah, our Egyptian player in Liverpool. I'm going to speak about COVID-19 and heart. So I don't have any conflict of interest. This is my agenda today. Today I'm going to speak about the story of COVID-19 in short, and then I'll give you a hint about the virus itself. So what is COVID-19? And then I will give you the epidemiology of the virus and the prevalence of the virus in the whole population, as well as in Kuwait in specific. I will give you a social question. Then we'll jump to the risk factors. Who is more liable to get COVID-19? What the COVID-19, how it does it work inside our body in general, and how it affects the heart in specific. And then I'll give you the most important cardiac manifestation of COVID-19, and finally I will give you the take-home message. So without any further ado, just jump to the story of the COVID-19 in brief. So our story begins here in Wuhan, which is one of the big China city, very close to the East China Sea. So frankly speaking, when I was trying to find some photographs for this city, I was really impressed because I found it very beautiful and fascinating city, which has more than 11 million people living there. But on the dark side of this city, they have what they call wet market. This wet market where literally you can find any animal on this earth to eat, including bats, including dogs and alligators. Sorry if some of you will find this photograph as a disgusting photo, but this could be a very delicious soup for somebody there in Wuhan. I'm sure that our Egyptian friend will remember this scene for Mohammed Hinedi when he was invited by a Chinese family to a cockroach dinner, and that was his impression. So actually, our story begins in Wuhan in the 8th of December when they discovered one patient with a severe unexplained respiratory problem along with fever. Then in the next few days, so many patients rushed to the hospital with the same problem and they accused a new virus called SARS coronavirus 2. So China started to warn everyone in China about the risk of the new virus. However, the life continues in China. In 8th of Jan 2020, more than 500,000 people were gathered in the same place in a very important event there in China. It's called Spring Festival. And from that time, the infection started to spread all over China, and from China to the rest of Asia, as well as in Europe, and in few weeks to the rest of the world. So in 11th of March 2020, the WHO declared that COVID-19 is a pandemic disease. From that time, the whole world woke up and they call it a crisis. So what is COVID-19? I'll give you a short brief about the virus itself. It's very, very minute in size. So it's only 70 to 80 nanometer in size. And to make it close to your mind, if you want to imagine the size of this virus compared to your body, so it is as the size of this chicken compared to the earth. It's related to the SARS family, which contains SARS and MERS and influenza virus. It has like 96% structure like the other previous viruses, but the problem that it's more virulent and is spreading very, very quickly like crazy. So this cartoon is showing the difference between flu and COVID-19. If you see here, flu, for example, one infected patient can infect 1.3 patients, while in COVID-19 might reach up to 2.5 patients. The incubation period, which is the period from getting infection of the virus until the symptoms appear, it's only 1 to 4 days in flu compared to 2 weeks in COVID-19. The hospitalization rate is only 2% in flu compared to 19% in COVID-19. The mortality rate is much higher in COVID-19, as you see, is 3.4% compared to 0.2% in flu. This cartoon is also showing the mortality difference between flu at the left side of the screen and COVID-19 on the right side of the screen in the same age group. So if we take patients at the age of 65 and above, for example, it's 0.8% mortality in flu compared to 2.7% mortality in COVID-19. So at least we have threefold increase in mortality in COVID-19 compared to flu. This cartoon is showing the course of the disease. Usually in the COVID-19, in the first 3-4 days, we have a mild symptoms, including fever and cough. And then in the fifth day until the 10th day, this is the time when the patient's condition started deteriorated and having more dyspnea and more symptoms. But actually the critical period started from day 13 until 21, where the storm can occur and the patient might go to the ICU and might even die. So how does coronavirus is transferred to the human? Sorry again to use this bad photograph, but they claim that it started always from the bats, and there is an intermediate host between the bats and the human. So in MERS virus, which is a Middle East respiratory virus, it's called it was the camel who is the intermediate host between the bats and the human. In coronavirus 1, which was there in 2002 and 2003, there was an intermediate host which is called civet cat, which to me it's close to a rat rather than a cat. But in COVID-19, which we have nowadays, this is the intermediate host between the bats and the human. It's called pangolin. I have never seen this one before, thanks to China. So how is transmitted from one person to another? So direct contact with infected person, this is number one. Number two, if this infected person is coughing or sneezing and the droplet will be dropped on some surfaces, like for example plastic or glasses or even metal, so and you get contaminated by this surface, so that you will get infected. And finally they say that it also could be transmitted through the airborne. So that's why social distancing term came up to the surface few months back. And we here in Salam International Hospital, we have to change our logo from this one to this one, just to cope with the social distancing. And just to show to you how much the importance of social distancing, you can see that a lot of people started to invent social distancing already of their own. So this cartoon is showing how much important the social distancing is. So suppose that we implement social distancing in 75% of people. So one infected person with COVID-19 can infect 0.6% in 5 days, and eventually they will infect 2.5% in 30 days. So what if we implement social distancing only in 50% of people? So again, the same infected person might infect 1.25%, 1.25 compared to 0.6 here. And then eventually they will infect 15 people in 30 days compared only here to 2.5. So what if we did not do any social distancing at all? So this is the problem, because only one infected person can infect 2.5%, and at the end of the day 460 persons might get infected in 1 month. So that's why social distancing is very important. As you all know that we still don't have any curative treatment for COVID-19 so far. So mask is better than ventilator, home is better than ICU, and prevention is better than cure. So now I will speak about the epidemiology of the virus, the prevalence of the virus in the whole world in general and in Kuwait in specific. So this virus affected more than 15 million people so far, and the numbers are increasing day by day. So this is the daily number in the whole world, is more than 275,000. In Kuwait, we have a total number of 62,000, and the numbers are also increasing every day. And the average number is from 700 to 750 every day. So this virus is making a challenge to all public health system, not only in Kuwait, but everywhere. Why? Because this study was done in 2018. As you can see here, we have only 2 beds for every 1,000 patients. So imagine that if we have a lot of patients coming to the hospitals in the same time with a severe respiratory problem, and all of them, they need ICU, that will make a really challenge to our health system. So that's why we had to think out of the box. So that's why most of the countries, they have to create what they call a field hospitals, maybe in a sport court, maybe in some schools, or even open places, in order to initiate or to create more ICU beds for those patients who cannot find beds in the ICU in the hospitals. Not only that, but also in the medical team. This study was done in 2016, showing that we have only 2.6 doctors for each 1,000 people in Kuwait. So the same story, if we have a lot of patients coming to the same time to the hospital, that will make a real problem. For helping people, for having a free online consultation, was totally free of charge, and we call it iTrust, and was working very effectively, and we were very appreciated by patients. So this virus, it was the cause of a lot of ICU admissions. Not only that, but many patients died secondary to the COVID-19 virus. And here you can see how many patients died in the whole world. It's more than 500,000. And in Kuwait, we have up to now 425, and the number are increasing. The average number is here in Kuwait is like 4 people every day, while it might reach to 700 and 800 in the United States every day. So that this is are not only from the patient side, but also from the medical team side. And if you look carefully to this photograph, it's not a portrait for a regular nurse, but if you look carefully, it was made of the pictures of the photographs of the medical staff who died as a result of COVID-19. So the percentage of people who died is different from one country to another. And this is depending on the following factors. So the phase of the epidemic, the number of testing per day, the registration and the power of their database, the demography, and healthcare capacity, including manpower, beds, and equipment, and finally, the governmental decision. These factors that will decide the percentage of mortality in different countries. Then I will ask you a social question. You don't have to click anything on the screen, but please just write your question on the chatting box, and Dr. Lara will be the one who to give me the percentage. So what do you think of the era of COVID-19? Do you think it's 100% bad? Is it 100% good? Is it mostly bad or mostly good? Please write A, B, C, or D. You have 15 seconds to answer. Is it good or bad or mostly good or mostly bad? Dr. Alala, did you get the answers?
Yes, it's coming, doctor. When you want me to finish, then.
I guess it's enough because the answer is very clear to me, I'm sure.
Yeah, I think most of the people answered C, doctor, but I think 2 or 3 people answered D, and I think 2 answered A also.
Ah, really? So some people, they answered D, mostly good.
Yes.
So they like COVID-19. That's great. I need to meet these guys later. So anyway, in my opinion, C is the correct answer. So let's see why. I agree with you that we have a lot of bad things in COVID-19 era. For example, staying at home without any work is boring for a lot of us. I'm sure that most of us are getting sick of wearing masks most of the time. I'm sure that most of us also are gaining weight like Barbie. We have a lot of bankruptcy in big companies, and this is one of the list of the air flight companies in the United States who had bankruptcy during the era of COVID-19. Unfortunately, many employees were terminated and they were released from job without any money. But in my opinion, we still have some light at the end of the tunnel. I'll explain why. So at least we had some more time to spend with our family that we missed to stay with them before. We realized how much the luxury that we used to have before COVID-19. So if you had an appointment to go to the supermarket, it was really a dream for most of us, especially during the lockdown time. So at least we give the earth enough time to breathe, and you can see the difference yourself. At least we are unified for the first time in our life on one thing, because every single person has to wear a mask all the time, regardless of the type of the mask, whether it's made of gold or plastic. And last but not least, we realized our real power in front of 70 nanometer virus. So I think now most of you agree with me that the correct answer was C. So now, what are the risk factors for COVID-19? Who is more liable to get infection? So this is an early study coming from China, and as you can see here, that hypertension, previous cardiovascular problem, and diabetes, malignancy, they are the most important risk factors, not only in ICU patient, but also in regular room patients. This is another study in China. They were checking the most important risk factors, not only in the patient, but among the medical team as well as the visitors. And they have found that hypertension, previous cardiac problem, renal disease, diabetes, obesity, and pulmonary problem, these are the most important risk factor to get infection with COVID-19. Not only that, but previous cardiovascular problem is not only a factor to increase the incidence of infection, but also to increase mortality. As you can see here, it is the most important one. It is reaching 10.5%. So how does COVID-19 enter our body and work inside our body in general? To know that, we have to review what we call the RAS system. I'll try as much as I can to make it as simple as possible. So the RAS system is starting always with a release of what we call angiotensinogen from the liver. This angiotensinogen will be converted to angiotensin 1, as you can see here, by the effect of renin, which is released from the kidney. This angiotensin 1 will be converted to angiotensin 2 through a substance called ACE1. This angiotensin 2 is very bad to our body. Why? Because it will cause stimulation of one receptor called angiotensin 1 receptor, and this finally will cause vasoconstriction, inflammation, fibrosis, and proliferation. Finally, this will cause hypertension, cardiac fibrosis and dilatation, thrombosis, and ARDS. So as you can see until now, ACE1 is a bad guy because it's forming a bad substance and it has a bad effect on the body. But fortunately, we don't have only ACE1, but we have another ACE which is called ACE2. This is released from many area in the body, we will see later. And this ACE2 is transforming this bad substance, which is angiotensin 2, into angiotensin 1 to 7. Which has exactly the opposite of angiotensin 1. So it's causes vasodilatation instead of vasoconstriction. It's anti-apoptosis, anti-fibrosis, anti-proliferation. So exactly against the other effect of angiotensin 2. And this will cause decrease the hypertension, decrease fibrosis, decrease thrombosis, and decrease the ARDS. So if I want to summarize this slide, ACE1 is a bad guy. Why it's bad? Because it's forming a bad substance which is stimulate this receptor, causing bad effect. And the ACE2 is a good guy here because it's getting rid of angiotensin 2 here and forming what we call angiotensin 1 to 7, which has a very good effect on the body. But this is not 100% true. What I mean that ACE2 is not always a good guy. So what is the link between this RAS system and COVID-19? Actually, this ACE2 is the link. So we will see how. ACE2 is not as innocent as it is. So it is like a double agent. So yes, we discussed that ACE2 is forming a good substance, which is angiotensin 1 to 7, and get rid of angiotensin 2, which is bad. Yes, this is good effect. So where is the bad effect of angiotensin 2, the ACE2, sorry. So the bad effect is that ACE2 is located at the surface of the cells. It's with the aid of other friends called ADAM17 and TMPRSS2. This is like a protein which help that the ACE2 is going outside of the cell, playing with bad friends here, which is coronavirus, and inviting the virus inside the cell started the virus to replicate and started the bad effect of the virus. So ACE2 here is going to play with another bad guy here, which is the virus, and inviting inside the home and making a mess like this. So the bad effect of ACE2 is it catch the virus and getting an invitation to him inside the cell and starting the process of viral infection. ACE2 is present everywhere in the lungs, in the GIT, in the heart, in the blood vessels, even in the brain. And that's why when a patient is infected with COVID-19, he has different symptoms everywhere, not only in the lungs, but also in the GIT or the heart or the blood vessels. So as I said before, ACE1 is a bad guy. This one is a bad guy. Why? Because it's forming a bad substance, which is called ACE2, and stimulator receptor called AT1, angiotensin 1 receptor, and has a bad effect on the body. Okay, so why don't we block this one, the ACE1, with drug, or block this receptor? And we have this drug, for example, you all know that Coverseal and tritase, which is called ACE, they are blocking this one. So angiotensin will not be formed, or we can block the receptor itself here. So finally, at the end of the day, we have no bad effect anymore. That's good. So where is the problem if we use this? I'm sure that most of you hear that these drugs has some relation to COVID-19. So let me ask you this question again, especially for the doctors. So if you have a patient, 65 years old gentleman, he is proved to have a COVID positive and he is an ACE inhibitor, like for example, Coverseal. What would you do next? Would you stop immediately the ACE inhibitor? Would you reduce the dose, or you increase the dose, or you continue the same treatment as it is? Please give the answer to Dr. Alala in 15 seconds. To be honest with you, this is a regular question in the clinic, not only from the patients, but also from other colleagues who read about the problem of the ACE inhibitor, that it might increase the infection, and they wanted to stop their treatment. So what do you think? Do we have to stop the treatment or not? What do you think, Dr. Alalo?
I think, doctor, most of the people answered go for D, option D, continue the same treatment.
So I'm sure that somebody stole in my presentation and give it to all of you before.
It seems like, doctor, now, because no one answered other than D at a moment. Everyone with D.
Great. I like this answer because this is a correct answer. So you made my life easy here, because yes, ACE inhibitor, they stop this ACE bad, which we used to call it a bad guy before, or the ARBs is closing the receptor itself, it's blocking the receptor itself, and finally we have a very good bad effect. So where is the problem here? The problem that they claim that this substance increase the ACE2. So upregulation of the ACE2 could be the source of the problem. So why ACE2 when it's increasing is a problem? If you go back to my slide again, we said that it's a double agent. It has a good effect and it has a bad effect. Why bad? Because it's going outside and playing with the virus, getting it inside the cell, and start the viral replication and the bad effect of the virus. So again, back to the first question. Shall we discontinue this treatment, or we continue taking them? I'm sure that most of the doctors were confused in the beginning of the era of COVID-19. But actually, this were solved completely in March 2020, because more than 12 societies of cardiology, and the most famous 12 out of them, they published these articles in 2020, and they said that we have to encourage doctors to continue taking this treatment and prescribing this treatment. This is, for example, the three of them: American Heart Association, European Society of Cardiology, and Heart Failure Society of America. They said that we have to continue taking the antihypertensive during COVID-19. And as long as these treatments are very beneficial to the patient in treatment of his heart failure, hypertension, or ischemic heart problem. Not only that, but the European Society of Cardiology, they said, continue taking this treatment despite of COVID-19 concern. Why? Because all of the speculation that came to the surface during the COVID-19 has no evidence to support it. Okay, so now we will go to how COVID-19 is affecting the heart. So many people, they think that the COVID-19 should affect the heart only through the lung, but this is not 100% true, because it might affect the heart through the immunopathology or hyperinflammation, or even direct affection of the heart. And we will see how now. Giving some punch to the heart. So actually, frankly, we have a lot of mechanism behind how the virus, or explaining how the virus is affecting the heart. One of them, if the virus is affecting the lung and we have hypoxia, or we have hypotension, or if the patient is having a previous coronary artery stenosis, so these three factors will eventually causing decrease the oxygen. In the same time, if we have inflammation, we will need more oxygen. So the demand is increased. So the supply is decreased and thus the demand is increased. And so we have now what we call mismatch. Mismatch means that the supply is not enough to give the demand. And that's why the heart will start to be affected. Not only that, but previous cardiovascular problem, coronary artery stenosis, we might have what we call plaque rupture, as we will see in the next videos. And this plaque rupture might cause myocardial infarction and affection of the heart muscle. Not only that, but we might have a direct myocardial toxicity. We might have a small thrombi in the artery we call microthrombi. We might have inflammation of the blood vessels called vasculitis. And this will end up, if you can turn your microphone off, that will be great. Thank you. So, and this will end up with the stress cardiomyopathy, as well as with hyperinflammation, it will cause stress cardiomyopathy or dilatation of the heart. These are the all mechanisms that might cause heart affection during COVID-19. Can you turn off your microphone, please? Amra, if you can deal with her. So now let's discuss what are the most important cardiac manifestations in COVID-19. Actually, we have a lot of cardiac manifestations. Guys, I will stop until you turn off your microphone, please, because I cannot continue this way. Thank you. So we have a lot of cardiac manifestations, including acute coronary syndrome, like acute myocardial infarction, whether it's a STEMI or non-STEMI. We might have acute myocardial injury without a vascular problem. We might have arrhythmia, and believe it or not, it's serious arrhythmia. And we might have heart failure or cardiogenic shock, pericarditis causing pericardial effusion and might end up with tamponade. And finally, we might have thromboembolic complication. And for the sake of time, and in my opinion, I will discuss three of them, including acute myocardial infarction, arrhythmia, and thromboembolic complication. These are the most important three categories that I think it will be beneficial to all of you. So starting with acute myocardial infarction, or acute coronary syndrome, as we call it. Let's give you this question because I think it's important to all of you. What do you think of the rate of infarction during COVID-19? As we said before, that COVID-19 is affecting the heart, maybe directly or indirectly, and it's causing acute myocardial infarction. So what do you think the number of acute myocardial infarction since we started this era? So is it increased, decreased, or did not change? I'll give you like 15 seconds to give the answer. Dr. Alala?
Yes, doctor, most of the people are answering for number 1A.
Great. So let's check. Unfortunately, this is not the correct answer. So my presentation was not stolen. Thank you. So I think the answer should be B. So the number is decreased. And I'm sure that most of you now having the same impression like this guy. So actually, we have a lot of publications since we started the COVID-19, and they were talking about the same issue. So where are these cases going to? We have decreased number of myocardial infarction, but how come? This is one of the studies that was published in the North California. They showed that we have 30% decrease in the number of infarction in 2019 compared to 2020. This is also another study from Lombardia, Italy, and this said that we have a reduction of hospitalization of myocardial infarction in Italy in the COVID-19 era. How come, guys? And this graph is showing this. So STEMI cases is decreased by 26% and non-STEMI is decreasing by even 65%. Is this true? No, this is true. This is not true. It's false. It's exactly like Maradona's goal in England in the World Cup in 1986. So the explanation behind that is because that patients were not able to go to the hospital during the lockdown time and during the quarantine time, especially in Italy and in China, and unfortunately, they were dying at home. So they were dying before even they reached to the hospital. And moreover, the hospitals and the ambulance there were quite busy in transferring cases, and they were not able even to bring these cases from here to the hospital. So numbers did not decrease actually, but it was increased, but they were not going to the hospital, they were dying at home. So what is the most common type of acute myocardial infarction in COVID-19? As most of you know that we have 5 different types of acute myocardial infarction. The first type, when we have what we call plaque rupture. Look at this video. This is the plaque in yellow. And here is the rupture happened at the lower end of the plaque. And then the clots will start to be formed and then propagated until it closed the artery. The second type, when, as we said before, we have decreased the oxygen supply and increased the oxygen demand. So we have mismatch between both of them, and this is second type. The third type, when we have a sudden cardiac death and myocardial ischemia is suggested. Number 4, if we have myocardial infarction after angioplasty, whether balloon or stent. And number 5, if we have acute myocardial infarction after surgery. But what are the most common types of acute myocardial infarction during COVID-19? The most important 2 types are the first 2. So what are the challenges that we have as doctors regarding cases with acute myocardial infarction during this era that we are living now? We have a couple of challenges, to be frank with you. First of all, we have difficulty in the diagnosis of cases of acute myocardial infarction compared to pre-COVID-19. Treatment strategy, whether to use thrombolytic therapy or to go for cath lab, this is also one of the challenges. PCI delay during the COVID-19 is also one of the challenges, and drug-drug interaction between the drugs that are tried in COVID-19 treatment and the drug that we are using in the cath lab. So let's start with the difficulty in diagnosis. I'll give you this example. This is the case number 1. He is 53 years old gentleman with COVID positive. He's complaining of fever, cough, and fatigue for 1 week. He's hypotensive, he's tachycardic, and his oxygen saturation is okay, is 98%, but his troponin is high, is 0.24%. So first thing that we usually do, we request an ECG and X-ray. The X-ray has no significant findings, but look at the ECG, we have significant ST elevation in the inferior and in the lateral leads. So fortunately, they request like an MRI for this patient just to be sure of the diagnosis, and they found some segmental wall motion abnormality. I'm sure that every cardiologist who is listening to me now, he would take this patient directly to the cath lab. And this is actually what they did. But very strange to find that this patient has absolutely normal coronaries. So what was the problem? The problem that he has a myocarditis. The virus is causing inflammation of the muscle and not affecting the blood vessels. That's why the diagnosis is difficult. So case number 2, it's the same story. He is 60 years old man, but he is not known to have COVID problem in the COVID positive, and he has no respiratory problem. He has ST elevation diffusely, as you can see in this ECG. His echo is 40%. Again, they took him to the cath lab, but fortunately, they found no problem in the coronary arteries. Later on, this patient developed shock and he needed a mechanical support. And then later on, he was confirmed to have a COVID positive, and he was also diagnosed to have myocarditis. So you can see that it's not easy to diagnose a case of acute MI in the COVID-19 era. So how can we differentiate between them? So really it's very difficult, but we need a lot of clinical judgment. We might need the echo, and finally we might go to the cath lab for a diagnostic coronary angio. So what are the other challenges? That we have treatment strategy. So some people in the era of the COVID-19, they were supporting to go to thrombolytic therapy more often. So they said that we have to limit the cath lab exposure and spreading of the virus between the medical team. And we used to give the thrombolytic therapy in 20 to 30% of people before COVID-19. So why don't we give it more? So they got a quick answer from the people who are working in the cath lab, and they were supporting the primary PCI because they said that PCI is by far superior than lytic therapy because it decreases all-cause mortality, it decreases reinfarction, and there's less intracranial hemorrhage in PCI compared to lytic therapy. Not only that, but patients who are received thrombolytic therapy, 40% of them, they might need to go again to the PCI. So why didn't they go to the PCI in the first place? And not only that, if we use thrombolytic therapy in patients with myocarditis, like the two patients we discussed before, it could be a catastrophe. So we have also one of the challenges during COVID-19 is called the PCI delayed. And this study is showing that the time that we take from the patient started his symptoms until he come to the hospital, or from coming to the hospital until he go to the cath lab, or inside the cath lab itself, it's increasing significantly in the COVID area compared to the pre-COVID area. And this cartoon will show where actually the delay is. We have the delay in 4 stages. First of all, the patient might find it difficulty to reach to the hospital, or the ambulance might be difficult to reach to the patient, or in the ER itself, because people has to make a lot of testing for the patient to rule out COVID-19 before sending him to the cath lab, or maybe also the delay will be in the cath lab itself, as we will see later. So as you all know that in the cath lab, we have to protect ourselves from radiation. As you can see, we are wearing here goggles, we have aprons, and we have shields, but during COVID-19, we have an extra protection from the virus itself. So why we have a PCI delay? Because we have a dedicated cath lab for COVID-19. So that if we have like 5 cath lab rooms, one of them will be, for example, a positive case. So if we have positive case, they have to wait until they finish the previous one. We have to wear full PPE, and we have to train our team on donning and doffing. Donning means how to put them on, and doffing how to take them off. Not only that, we have also to minimize the number of the staff that you are working in the cath lab. So remember that this virus will live with us a rather longer time than we expect. So remember that it's a marathon, which takes a long time, and it's not a sprint. So we might need to stay for 15 to 20 minutes to sterilize the cath lab between each patient and another. So the other, the last challenge in the acute MI is that we have a long list of drug-drug interaction between the drugs that we are used here to treat the virus and the drugs that we give, like antiplatelet drugs. So what about the arrhythmia? So during COVID-19, there are some patients who are liable to get arrhythmia more than others. Who are their patients? These patients are the patient with previous cardiovascular problem, this patient who are having hypoxia or shock, this patient with systemic inflammation, electrolyte disturbance, or prolonged QT interval, or patient with fever. So I have 3 main questions here as regard the arrhythmia. Patient with previous arrhythmia, are they more risk during COVID-19? Yes, the answer is yes, because 60% of them, they have to have this arrhythmia. Two, does COVID-19 16.7% arrhythmia in patients, whether they had it before or not? How the arrhythmia is happening? If we have a patient with ARDS, if the patient is having sepsis, so he might have AF or VF, ventricular arrhythmia. If he's having acute kidney injury, he might have AF bradycardia or ventricular arrhythmia. Or if he's having a storm, cytokine storm, he might have AF or prolonged QT interval. So what are the most common type of arrhythmia in COVID-19? We have tachycardia, and as you can see here, AF is one of the most important one. It's 19%, followed by non-sustained VTAC. Unfortunately, the most of serious arrhythmia are occurring in a small percentage of patients, from 3 to 4%. So what about the bradycardia? Yes, we can also have bradycardia during COVID-19. The most important one is severe bradycardia or complete heart block. The explanation is not known. So how we diagnose it? If the patient is admitted to the hospital, so we usually do an ECG, or through the monitor we can diagnose this arrhythmia. Or if this patient is at home, so we can have like a Holter monitoring for 24 hours, or ELR that might take like 2 weeks or 3 weeks. We might also have a patient device that he can send to the doctor through the specific software, or even we can do it through the telemetry. So number 3, does COVID-19 medication cause arrhythmia? This is very important question, because I know that most of you heard about these 2 drugs, hydroxychloroquine and azithromycin. So yes, hydroxychloroquine was widely used in different countries, especially Italy, Spain, and China. And they had a very good effect in the beginning as it decreased the viral load, and especially when they combined both drugs together. Even Donald Trump, he said, I'm not a doctor, but physicians should consider using hydroxychloroquine. But he got a very quick answer from Mayo Clinic. They said it's inexcusable to ignore the hydroxychloroquine side effects. And what are these side effects they are talking about? This is the normal ECG, and we have what we call prolonged QT interval. So to know the prolonged, you have to know first what is the normal QT interval. The normal is 460 in both male and female before puberty. And then after puberty, it should be less than 470 in males and 480 in females. And this is an example of prolonged QT interval. This is from the beginning of the Q to the end of the T. If you compare to this one, it will be shorter. So what does the QT interval might cause? It might cause what we call torsade de bas. This is a very serious ventricular arrhythmia, which might end up with ventricular fibrillation and death of the patient. So it's quite dangerous. So if we want to start this treatment in any patient, what is the algorithm that we should use? First of all, we have to check this QT interval. If the QT interval is less than 500, so we can start using the treatment, but not freely. We have 500, we have to consider stopping the treatment. If it is less than 500, so we have to use it cautiously, and we keep monitoring of the QT interval. But what if the QT interval is from the beginning is more than 500? We cannot use it. We have first to correct this QT interval if it is possible. First of all, we can give like magnesium sulfate, we can improve the electrolytes. If we could manage to decrease the QT interval less than 500, this is the time when we can start the treatment. Otherwise, we have to find another treatment. So Finally, the FDA said that it's not possible to use and it's not authorized to use the hydroxychloroquine because it has no clinical trial so far is available to prove its efficacy. And not only the QT interval, but we have a long list of drug-drug interaction between the treatment that they are trying now to treat COVID-19 and our regular treatment that we are using in daily life, especially the antihypertensive treatment, the anti-arrhythmic treatment, and the anticoagulant treatment. So the final thing is thrombosis. Thrombosis is very important to all of us. And I'm sure that you heard that a lot of patients, they are having thrombosis during the COVID-19. And who is more liable to get thrombosis? These are the people who are more liable. Those who are having acute illness, bedridden patients, those who are having genetic predisposition, those who are having fever, diarrhea, sepsis, liver injury, CKD, chronic kidney disease, COPD, heart failure, and malignancy. And when they have these risk factors and they started to have the infection with this virus, there's a lot of cytokines will be released, including interleukin 6 and CRP, and then the thrombi will start to be formed. So how can we know that this patient is having a thrombus or not? They found that if this patient is having a high D dimer, so he is more liable to have a thrombus. This is as a study is coming from France, is comparing between patients who died in the red and patients who are survived in the blue. And you can see the difference here. The D dimer is quite high in people who died with thrombosis compared to the patient who survived without any thrombus. So D dimer is very important, but unfortunately is not very accurate because there are other causes that might increase the D dimer, not only the thrombosis. So this is how the thrombus is formed. This is the alveoli and this is the endothelium. The endothelium is supposed to secrete a lot of substance that decrease the thrombosis. But if we have the virus coming here to the alveoli, this virus will cause destruction to the alveoli and the release of substance, as we said before, like for example, the interleukin 6 and TNF and a lot of them. And this will exactly do the opposite. So it will increase the thrombosis rather than decrease the thrombosis. So the thrombus might be in the veins or maybe in the arteries. So if in the veins, it will cause like DVT, like this red leg, for example, or it might migrate from the lower limb to migrate and stay in the lung, causing pulmonary embolism. Or it might be in the arteries. Arteries, as we said before, acute myocardial infarction, or maybe in the brain. And we notice that it's affecting a lot of patients, young patients in the large cerebral artery, causing a significant infarction, or even in the peripheral circulation. And they now give this a term called COVID-2. So I have three main questions here. Is it easy to diagnose thrombosis in COVID-19? Actually, the answer should be no. So the D dimer, as we said before, is one of the parameters that increase, but actually is not a very specific because it might be increased due to inflammation. So how can we suspect the thrombosis then if we don't have a D dimer as a good marker? So if we have a deep vein thrombosis, if we have hypoxemia, which is disproportionate to the respiratory pathology, or if we have an echo to this patient and we found a dilated right side. At this condition, we have to suspect that this patient having thrombosis. So the imaging also could be difficult because it's difficult as we might transmit infection from one patient to another, or from one patient to the team. If he is transferred from the ICU to the radiology department, some patient, they might to be in the prone position, so it's difficult to do CTPA. So even the imaging technique that we use to diagnose thrombosis might be also difficult. So how can we do it? We might rely on the echo. And the echo is showing here a big thrombus in the right side. This is a very good confirmation. Or we might have a dilated right side, as you can see in this echo. or even dilated inferior vena cava, as you can see in this photo. So what is the second question? What if we have a patient inside the hospital? What is the prophylaxis that we have to give to prevent thrombosis? As I told you before, prevention is better than cure. So we don't have to wait until the patient is developed a thrombus and then we start to treatment. So we have to prevent the thrombosis in the first place. And the more the severe the case is, the more indication to start the anticoagulation prophylaxis. So who should receive the anticoagulation? Hospitalized patients, especially moderate to severe COVID-19, patient with severe respiratory failure, patient with other comorbidities including heart failure and cancer, or bedridden patients. So what we should give this to this patient, either we give low molecular weight heparin or we give unfractionated heparin. Unfortunately, we don't have any drug-drug interaction between heparin and the drugs that we are used to treat COVID-19. So what is the dose we have to give? We usually give the prophylactic dose, as we all know, but they tried in this study to give a therapeutic dose, which is a very large dose, and they found that it's very effective, but frankly speaking, the data is very limited. So also we can use this intermittent pneumatic compression to prevent the occurrence of thrombosis in our admitted patients. So what if our patient is at home, he is not in the hospital? So what is the prophylaxis that we should use? Do we have to give every single person who is having COVID-19 staying at home a prophylactic antibiotic? Of course not. So for high-risk patients who have the incidence of thrombosis, those are having active cancer, those are having a bedridden or immobility, old age, morbid obesity, and previously recurrent or recurrent DVT. And of course, they should have a low risk for bleeding as well. So what to give? We also can give a low molecular weight heparin through the injection subcutaneously, or we give a novel anticoagulant, which is called NOAC. For how long? They said that 45 days might be more than enough, and in a new study, they said up to 3 months. What about the pregnant woman? The pregnant woman, they said that they deserve also further attention. Why? Because they are more at risk, not only during pregnancy, but also after labor. And so prophylaxis is very, very important. And also heparin is safe in pregnant women during the pregnancy. So now going to the take-home message. SARS-CoV-2 is one of the SARS family, but it's more virulent and is spreading more quickly. The virus mainly attacks the lung, yes, of course, but it also can attack the heart. Risk factors for COVID-19, which one of the most important is previous cardiovascular problem, as well as hypertension and diabetes. Most important cardiac manifestation is including acute coronary syndrome, arrhythmia, and thrombosis. ACE inhibitor or ARBs, which are the drug that we use to treat hypertension, heart failure, they should not be stopped under any situations just because of COVID-19. Primary PCI is the preferred reperfusion strategy during COVID-19. And COVID-19, as you know, it might increase the thrombosis, and prophylactic anticoagulant is very important, especially in ICU patient and after discharge. تقبل الله منا منكم again, and Eid Mubarak, and thank you for your listening.
Thank you very much, Dr. Islam. Yet another interactive and interesting presentation. And I think everybody enjoyed it, including me. There was some, I think the people, we were trying to mute them down, maybe that bothered you, but Alhamdulillah, it went, rest of the time, it went very well. There is one question, I think we can start the question answer session if you are ready,
Sure.
Doctor.
Sure.
There is one question which came till now, although it's not directly related to the heart, but in case if you can answer, although I know you are not an ENT specialist. Someone asked that if COVID-19 positive patient did not resume the anosmia and even after the 3 months of corona attack, is there any treatment option available to regain it?
The answer, I don't know. So it is one of the common manifestation of COVID-19, but frankly speaking, most of the patients who got loss of the this one, so I think most of them, they regain it back again in few times. But if they stay more than 3 months, it might be difficult to regain the smelling sensation again, but I'm not sure. It should be answered, I think, by consultant of ENT anyway.
Dr. Islam, if you allow me, I can just add one thing to that.
Sure.
It was observed that they said that if it is usually resumed in 1 month of time, but if it is not, then what you can do, it's like a rehabilitation. So you can start doing smelling slowly with essential oils or multiple smell every day. So sometimes by the virus is directly damaging the olfactory bulb. And then the nerve have ability to regenerate. So for that reason, if you do it daily, like sniffing of essential oils and multiple smell, you might get better. In some of the studies, they did it like this, in case if they can help someone with that.
I guess that is a satisfactory answer, but we are still in the learning phase during this era because, you know, all the studies that we have is a single center studies, and they are done on a minority number of patients. So I think we are still in the learning phase. Maybe they're gonna, with the treatment that they are trying now, maybe the smelling will come back even earlier. We still don't know.
Dr. Sania has added a comment that it is some studies showed that it can be secondary to thrombotic episode. So if the thrombosis recovers, it might recover too. This is just an addition which is added there. Another question, Dr. Islam, is what about thrombosis in pathogenesis of the disease itself? This is the question. I'm not sure, actually. Maybe you can interpret it.
Maybe the question, Dr. Shafai. Okay, so I skipped the pathogenesis because it's a little bit complicated, but you know, it is regarding the endothelium, and the endothelium, as you know, that it's they consider it as an organ. It's not just a simple lining of the blood vessels. This endothelium it's working by releasing a lot of substance, which is decreasing the coagulation. And then when the virus is coming and attacking the alveoli, this is the time where a lot of substance is coming from the alveoli, which called as the cytokines. It's affecting the endothelium, causing what we call endothelial dysfunction. So instead that we have a substance that decreases the thrombosis, we have a substance that increases the thrombosis. Okay, so and they found that it's affecting not only the lungs, so it's affecting a lot of blood vessels inside the heart and causing a lot of infarctions here and there. And that's why we might have a patient with ST elevation, and when we go to the major big vessels, we might find it completely open. But at the end of the day, the patient is having a dilated heart and he's having a big issue. So the problem can be explained by the endothelial dysfunction.
Okay, may I just ask a question here?
Dr. Ham.
The question is actually coming for me as regarding pathogenesis. And the thing is, why I ask this question, because actually anticoagulants in these patients are given even without the high risk factors we were discussing. I mean, the pregnancy, the old age, the cancer. It's actually the anticoagulants are given according to the D-dimer level. And the threshold for giving the anticoagulants has been different in many studies, more than 1,000 or 1,300. It differs from one study to another. But what I'm trying to say is heparin is given regardless of the risk factors of the patient if he has severe manifestations, because it's part of the pathogenesis. Number two, regarding the diagnosis of pulmonary embolism, depending on the echo, what you have showed is actually massive embolism diagnosis. But what about the subacute? What about the mild embolism, mild thrombosis in the circulation? It cannot be diagnosed by echo in this way, right?
So to answer the first part of the questions, I agree with you that a D-dimer is one of the markers for thrombosis. However, it's not a very specific marker because pro-inflammation alone can increase the D-dimer. I agree with you that a lot of studies, they started to give heparin according to the D-dimer level, and before reaching at least 6 folds of the D-dimer. So because if you reach 6 folds, mean that the patient in a very bad condition, and maybe he will having a storm. So regarding the dose, actually the most accepted dose is the prophylactic dose in patients with moderate to severe symptoms. And the prophylactic dose is to give, for example, the 40 to 60 milligram low molecular weight heparin once a day, or to give 5,000 heparin, unfractionated heparin, 2 to 3 times in a day. This is the dose that they give. But they also give the therapeutic dose, although it was a very small study and it was not, I mean, you cannot take it as a guidelines. This is number one. Number two, regarding the diagnosis of pulmonary embolism, as I mentioned, it's very tricky and it might be difficult for a lot of reasons. First of all, it might be difficult to move the patient from the ICU in a serious condition. He might need a ventilator, he might need to be in a certain position, and to take him to the radiology department to perform a CTPA, or for example, a lower limb duplex. So that's why clinical judgment is very important, as well as in echo. The echo might help you in the diagnosis in case that you have a highly suspected case and you cannot transfer him from the ICU to the radiology department for CTPA. The echo is showing, as you all know, the most important thing is dilated right side, as I show in one of my photographs. You must not have a big thrombus as I showed in the first photo, but at least you might have in right side or right ventricular dilatation, which was not there before, or at least you have marked increase in the size of the RV compared to a previous study. And the number two, you might see a thrombus, a small thrombus, maybe in the main pulmonary or even in the branches of the pulmonary, or you have a dilated inferior vena cava, which is not responding to the inspiration. So these are the signs, along with clinical data, along with the D-dimer, so you can start to build up your diagnosis and say that he might have a pulmonary embolism. But the diagnosis is quite difficult, as you say.
Thank you, Dr. Islam. I think, thank you, Dr. Shafi, for asking this question, because Dr. Islam gave a very elaborate answer, and I think it made everyone to cancel their questions. I think, Dr. Islam, thank you very much. You lived up to your reputation, and your presentation, and I think was very important. And then I think it went very well. There is only one question, the last question, maybe if we can take it quickly. It came, and then this will take it as a last, that if for the heart attack increases develop troponin T, but COVID patient showing prolonged, is there any other cause?
The QT interval, you say?
Trop T.
Troponin T?
Yes.
So actually, this is one also of the biomarkers for myocardial injury. So the problem that as I showed in one of my cases, the case number 1, it has a different type of troponin, which is called troponin I, which is even more specific than troponin T. The troponin I, when it's increased, or troponin T when it's increased, it means that the muscle has been injured. But whether it's injured due to ischemia or injured due to inflammation, it could be difficult to discriminate. So that's why I showed the case number 1, who came with some fever and some fatigue, and then they made an ECG. He had some changes, and the troponin was high. And at the end of the day, they took him to the cath lab, and finally they found that the blood vessels were all open, so the coronary were completely normal. So it's a good parameter is exactly like pulmonary embolism, as I said before to Dr. Shafi. You have to build everything all together. So your clinical judgment, the type of the chest pain that he is having, the number of the risk factors that this patient is having, and the ECG changes. Is it diffuse or localized? Do you have diffuse ST segment elevation or not? Echo is very, very important because you can check if we have segmental wall motion abnormality or we have global decrease in the contractility. And then at the end of this, you can build up your diagnosis, whether this elevation of troponin I or T is due to a vascular problem or it's due to a heart muscle problem, inflammation. And at the end of the day, the very conclusive tool is to go to the cath lab and check the coronaries. If they are open, it means that it's inflammation of the muscle. If they are closed, so most probably this is due to ischemia. So I hope that this has answered the question.
Thank you very much, Dr. Islam. With that, I think we are coming to the end of the session. Thank you everyone for joining with us. Thank you the IT team, Dr. Ruba, and all the people who were involved in this excellent presentation. And thank you, Dr. Islam, again, for giving us an elaborative response of COVID-19 with heart. So
thank
inshallah,
you so much.
Eid Mubarak to all of you, and inshallah we will meet after the Eid within another session, inshallah.
Inshallah.
So
thank you so much.
Good night.
Good night. Eid Mubarak. Assalamu alaikum.